free to submit your questions into the chat, and we have a few starter questions for the folks, and we'd love to hear your questions and answer them as well. So we're going to lead things off tonight with Dr. Burtness. She is a professor of medicine and medical oncology, co-leader of the Developmental Therapeutic Research Program, and disease-aligned research team leader for head and neck cancers. Dr. Burtness is internationally recognized for research in head and neck cancer and leads national and international trials of targeted therapy in head and neck cancer. She received her medical degree from SUNY at Stony Brook and completed a residency and internship at Yale. Of note, Yale Cancer Center was recently awarded a 5-year, $11.7 million grant from the NIH to fund the Yale Head and Neck Cancer Specialized Program of Research Excellence, referred to as a SPORE. And Dr. Burtness serves as a principal investigator. The goal of that program is to address critical barriers to treatment of head and neck squamous cell carcinoma due to resistance to immunotherapy, DNA damage, and targeted therapy. Without further ado, here is Dr. Burtness.
Thank you so much, Bruce. I'm going to share my slides, and I'll just start off by saying hi, because I see some familiar names in the attendee list, and I'll start off by saying something kind of personal, which is that I've been side by side with a lot of people who've gone through treatment for head and neck cancer. And one of the great things about that is that it's a highly curable cancer. And, patients who've been through that treatment come back and see me for many years. And there's a lot that's very wonderful about that. The flip side is that the treatments that we use have a lot of side effects. And I think even in situations where we're really confident about cure, there are reasons for us to always keep our eyes on the question of whether or not there are different ways of doing things. And then the other thing is that sadly, sometimes these cancers come back and the treatments that we have not always been successful. And so I'm going to do a very loose, very general overview, just kind of trying to position sort of, as I talk about the different aspects of head and neck cancer, where do I think research comes in, and why is it that we need $12 million from the NIH, or that we sometimes talk to our patients about, hey, do you want to participate in research? Like, why is it that we're always looking to see if there's a way to make things better? So I'll start off with the question of where head and neck cancer comes from. First of all, this is, Bruce will show you much better, Dr. McGibbon will show you much better pictures about how we do radiation treatment planning for head and neck cancer. But this is an example of a tumor and the spread of the cancer to the lymph nodes, and kind of the amount of these critical parts in the head and neck that might have to be exposed to something toxic like radiation, or why we might need to add chemo to radiation. So historically, we've had two predominant kinds of head and neck cancer, and we sometimes call them HPV negative and HPV positive. Those of you who've been in treatment in recent years have probably heard that language. So HPV negative cancers are related to aging. They're more common in people who've used cigarettes or used alcohol regularly. And then over the past couple of decades, we've seen another kind of head and neck cancer emerge, which is driven by the human papilloma virus. And the interesting thing about that is that human papilloma virus related tonsil cancer is much, much more sensitive to radiation and chemoradiation and surgery. And so when we talk about maybe wanting to cut back on the intensity of treatment for some patients, it's because our treatments over the years were designed mostly for people who had HPV negative kinds of cancer. And then as we started to apply them for patients who had HPV positive cancer, sometimes we started to wonder, is this a little much? So obviously the best way to approach any kind of cancer is never to have it in the first place. And so there's a lot of research that goes into how could we prevent head and neck cancer. And one of the most important things that we could do would be to induce people to quit smoking. And here again, research has been really helpful. When I was in medical school, they used to say to us, well, you know, the more that you talk to your patients about tobacco, the more likely they are to quit. But it turns out that you have to talk about it in a way that makes sense and that can help people see sort of the upside of quitting. It's also the case that support groups and counseling and medication can be helpful for people who want to quit smoking. We try to also talk to people about minimizing alcohol exposure. So that could either be if somebody's drinking alcohol too heavily, or it could be excessive use of alcohol containing mouthwash. And then there's some medications that we look at for people who seem to have recurrent precursors to head and neck cancer. And then trying to prevent human papillomavirus. So this is the same virus that can cause an abnormal pap smear. And we're now seeing that tonsil cancer and cancers at the back of the tongue are more common than cervix cancer as the most common HPV caused cancer in the US. And so we strongly recommend that boys and girls, men and women up to the age of 45 should think about getting the vaccine against human papillomavirus. Just, you know, a quick overview of what are the presenting symptoms that make us want to check a person out and make sure that they don't have a head and neck cancer. A really common thing is a painless lump in the neck on the side over here that usually turns out to be I mean, not usually, but if it's related to a head and neck cancer, could turn out to be that there's a lymph node there that's involved with the cancer. Some people have a sore throat that doesn't go away, especially concerning if that's always on the same side. Some people have chronic sinusitis or trouble with sleep apnea. Coughing up blood could be a sign, unexplained weight loss, and then it's not common for an adult to have an earache. So we'd always want to explore that. So in head and neck cancer, as I was saying, we have treatments that can be curative, but they're a little tough to take. And we realize that we really have two separate kinds of cancer, the kind that's driven by the virus and the other kind. And so we feel like some of the big questions for us in the field are how can we identify patients who are the most sensitive to radiation or the most likely to be cured by surgery. And for those patients, try to focus on reducing the likelihood that they're going to have late after effects or chronic toxicity from the treatment. And then in other patients where we don't see those same predictors of a really strong response to treatment, how can we find new therapies or overcome resistance to the treatments that we have? So let's start with the good news, that the people who are really responsive to treatment and how we're thinking about where we could back off on treatment. So we consider that there might be some patients where we want to reduce chemotherapy exposure. There might be patients who, excuse me for a second. I'm sorry. No, I'm really sorry, everybody. We might reduce chemotherapy exposure. We might shorten the duration of radiation exposure, or we might try to avoid giving so many different kinds of treatment. And to reduce late morbidity, we could reduce the radiation dose, reduce the field of the radiation, or avoid giving chemotherapy together with it. Another thing that we're starting to think about with head and neck cancer is that it can be a cancer where the immune system is not helping to fight off the cancer. And so what happens here is that a cancer might not give off the signals to the immune system that says that these cells are foreign and don't belong here. A cancer might put out signals that put the brakes on immune cells, or they might stimulate cells which inhibit the function of the immune system. And so there are treatments now that take the brakes off the immune system, and these can work for both kinds of cancers, for HPV positive and HPV negative. And what's really remarkable is that for those patients where these treatments work, where turning the immune system back on against the cancer is effective. You can see that in some cases we can make the cancer go away entirely, and that can endure for years. We're now learning. For some of the patients where we need to think about going back on anti-cancer treatment because the cancer has recurred, we've always pretty much centered around one chemotherapy drug, and that drug is a medicine called Cisplatin, which has been around for a long time. And when patients become resistant to Cisplatin, there have not been a lot of other drugs that work. And one reason for this is that there's an abnormality in head and neck cancers, oh, sorry about that, in a protein called P53, which is the normal regulator of cells moving through the cycle. And when that is not there, there's nothing to put the brakes on these cancer cells, and they just keep dividing and growing, which can be a reason that cancers can grow even when they're being exposed to chemotherapy. And so some of the research that we're doing at Yale to try to find new treatments for head and neck cancer involves trying to find ways that we could manipulate cancer cells even though they don't have this normal ability to put the brakes on. And so what we do is we give two treatments. We give a treatment that's directed to this, and obviously here I'm showing you results from the laboratory. This is not yet in patients, but this is something we're trying to move forward. So we give a medicine that, so here's a picture of a cancer cell that's trying to divide in two. And you can see those green lines, those are the spindles that are going to pull the parent cell into two daughter cells. And we can give a medicine that messes up that spindle formation. And you can see that instead of pulling into two cells, that cell is now going to pull in 4 or 5 different directions. Then we can give another medication that kind of actually speeds up the cancer cell going through that process of trying to divide. And you can see here when we give the two medicines together and you have these spindles pulling in all different directions and the cell trying to divide, the cell will just explode and die. And so this is just sort of an insight into some of the ways that we're trying to develop new cancer treatments. We're also really interested in ways that we can jazz up the immune system more. I showed you an example of a medicine called pembrolizumab that works to make the immune system stronger. Turns out that in human papillomavirus associated cancers, there's some treatments that we can give to try to prime the cancer for immunotherapy. And so that was just a real brief introduction, interrupted by my family in the background. But just to sort of sum up, I think what we see going on with our head and neck cancer program at Smilow is that we try to start from a promise to deliver really exceptional multidisciplinary care across chemotherapy, radiation, surgery, but also that we want to be able to make available for you, our patients, clinical trials that will try to make treatment better, whether it's focusing on reducing the toxicity of treatment or, when necessary, trying to add new treatments so that the outcome will be more successful. And we are also located in medical school, and many of you have seen our residents and fellows in the clinic because we are also developing the next generation of researchers in this disease. So I'll leave it there and stop sharing and kick it back to Dr. McGibbon.
Thank you very much. That was fantastic. Move on to Dr. Ben Judson. He's a professor of surgery and chief of the division of otolaryngology at Yale. He specializes in the surgical treatment of benign and malignant tumors of the head and neck. His clinical interests include oral cavity, pharynx, and larynx tumors, as well as salivary tumors, thyroid malignancies, skin cancers, and sinonasal tumors. He attended Middlebury College, obtained a master's degree at University of Pennsylvania, and graduated from the Jefferson Medical College. He then completed a residency at Georgetown University in otolaryngology, and then a fellowship at Sloan Kettering in head and neck surgical oncology. His research interests include investigating outcomes and quality in head and neck cancer therapy, participating in clinical trials, and supporting a biorepository of head and neck cancers at Yale that enables basic and translational science. Here's Dr. Judson.
Thank you. Thank you, Bruce. It's a pleasure to be with you. I will apologize in advance. I'm actually unexpectedly talking to you from the surgeon's lounge. My plan was to be home in my office, but I had a little bit of a longer, more complicated day. All is good. But in advance of someone, I have the potential to be interrupted here as well. So I also want to reiterate Barbara's message, just to say hello to those in the audience that we know, and thank you for listening in. So, I'm going to talk about a couple of new surgical techniques or approaches in head and neck cancer. Let me just start my slides here. Actually, so I have no financial disclosures. I'm going to show a couple of surgical photos. They're not anything too terrible, but just to forewarn you, if that's not something that you would want to see. I'm really going to, so the two surgical techniques I'm going to talk about that are new are transoral robotic surgery, and then the other is sentinel lymph node biopsy for oral cancer. But I wanted to also say a few words about multidisciplinary care in head and neck cancer. And really having these new techniques and treatments is great. Probably in terms of surgical as well as others, probably the most critical thing in terms of doing a good job for taking care of patients is figuring out which treatments to use for each one. And to have a team that's working together to do that is critical. So, in head and neck, when we say head and neck cancer, it can mean a lot of things. We see salivary gland cancers and advanced skin cancers, soft tissue tumors, some thyroid cancers. But then we also, probably the bulk of what we see are squamous cell cancers of the upper air digestive tract. And even within that, there are a lot of different areas where they can show up. They can be in the mouth, and different parts of the throat or the voice box. And in each of these areas, you've heard a little bit about this, you'll hear a little bit more. There are different risk factors, and cancers in these different areas behave differently, and the best treatments for each of these is different. And so it's so critical to have a team that's working to come up with the best treatment for each one. So just wanted to start by saying that, head and neck cancers are a diverse group of cancers. There are lots of different ones. Each of these cancers are clinically and biologically distinct, and having an individualized treatment plan for each person, for each individual and for their specific cancer is critical. Having a team of an oncologist or oncologists, a radiation physician, a surgeon, speech therapist, nutritionist, nurse coordinator, physical therapist, occupational therapist. You'll hear from some of those folks later in the evening. Is so important to make sure that the team is using each of these great treatments in the right combination for each person, and that we're taking care of you to the fullest extent to get you through the treatment. So the first surgical treatment I'm going to talk about is transoral robotic surgery. And this is a treatment that is used to address tumors that are in the oropharynx. So this is a sort of part of the throat that is partially visible through the mouth, but also sort of partially not visible. And so this is an example of a tonsil or oropharynx tumor and cancer. This is looking in someone's throat, and you can see the uvula hanging down in the middle and the back of the tongue, and then you can see a cancer or growth there. And from a surgical perspective, looking in here, I can think, well, geez, I could get, I can see around some of this tumor, but it's hard to see around the whole thing. And so historically, even for small or medium-sized tumors, a quite large surgery was needed to get to these areas. And that involved sometimes, splitting the jaw, making big incisions, sort of a maximally invasive surgery, mostly for exposure. And that was something like that. And so to address this, this approach of using a robot operating through the mouth to get to the oropharynx has come about. This is an example. This is in our operating room. This is the newest robot. It's the single port robot. I think we're the only, certainly the only one in Connecticut to have this robot, one of the only few institutions in New England to have one of these robots. Basically, it's in the operating room. There's a camera and operating arms that are introduced through the mouth. An assistant sits at the bedside to keep an eye on things. And the surgeon actually sits at a console next to the patient and is able to control all these arms and cameras. And I'll show a picture of what this looks like. Basically, we're able to look, this is sped up, not real time. These tiny arms, we're able to control them and work in a space that we wouldn't be able to get our fingers into, and we're able to see in a way that would not be able to see just looking looking through someone's mouth. And so this is an example of removing a tonsil cancer, and it just allows a sort of precise aspect to the surgery that is not achievable without the use of the robot. And you can see it's a relatively bloodless, very careful, it's sped up, but usually, very careful, deliberate surgery to make sure that we're getting everything out that needs to come out while not taking more than we need to take out. And so you can see this is just finishing up. The whole tumor is able to be removed here. It was a small tumor. And you can see there's what's left is sort of a raw area in the throat that's allowed to heal in. So this is a fantastic advancement in terms of surgical technique. Again, I mentioned the most critical piece with these is knowing when to use them. Just because you've got it doesn't mean it's the best thing for every patient. So this is an area where there's still a lot of research happening. I will call out or mention, the largest study in this area is a study called the Ecog 3311 trial. This was done at a number of institutions across the United States under the supervision and leadership of Dr. Burtness. And patients here were with HPV positive oropharynx cancer were treated with transoral robotic surgery. And then based on their pathology report, they were either treated with no additional therapy, or they got chemotherapy and radiation, or if they were sort of in a middle risk group, they got randomized to standard dose radiation or low dose radiation. And the reports of the results so far indicate that those who received the lower dose radiation had just a good cure rate as those who received the standard dose. So this is allowing us to use lower dose radiation in some patients after having had a transoral robotic surgery. So this surgery has been around for we've been doing it here at Yale for 10 years. This is one of the first patients I operated on with tours. She, had a small cancer, was able to be treated with this surgery alone, and has done very, very well. So just summarizing about transoral robotic surgery, it has functional and cosmetic improvements compared to open surgery. The role in multidisciplinary treatment of oropharynx cancer is emerging as a result of studies like the one I mentioned. And this is probably the most critical thing, is to know when to use it. It's not the best treatment for everyone, or for many actually, but knowing when it's useful is critical. It can be particularly useful for earlier stage disease, and for those rare patients that are just not able to receive radiation or chemotherapy is another time where it's been useful. So the other type of new surgical technique I wanted to mention is sentinel lymph node biopsy for oral cancer. So the oral cancer is not the oropharynx, it's in the front. This is an example of an oral cancer. It's a growth in the mouth. Oral cancers are generally treated with surgery. This patient had a surgery to remove the tumor. This was actually 5 years ago this year. I just saw the patient back. Here she is. She's doing great. She was actually able to, I didn't mention dentists. It's important to have dentists as part of the team. She was actually able to have a denture made here. But one of the sort of the dilemmas with treating patients with oral cancer is that, most of them present with early stage disease. So they've got a tumor growth in the mouth and no evidence of it having spread to the neck. But we know even when a scan of the neck is clear, there's some risk that the cancer may have spread. And so in the past, that has mostly been addressed by doing surgery also on the neck called a neck dissection, where we remove a bunch of lymph nodes from the neck. And here's an example of what an incision looks like. And here's an example of what's removed. This surgery is done, and it's done because there are studies that show that there's a survival advantage to doing this an elective neck dissection, because it picks up those patients where the cancer has spread and allows those patients to be treated with surgery and oftentimes with radiation as well. So there's a benefit to it, but the majority of patients who have this surgery, the cancer is not spread to the neck, and so they go through essentially a surgery that is, only in retrospect do we know it was unnecessary. And so the question has come, is there a way to figure this out or to assess this without doing as big a surgery? And one of these techniques that's emerging now is to do what's called sentinel lymph node mapping. This is a technique that's frequently used in to treat other types of cancers, like melanoma and breast cancer. It has not been extensively used in head and neck cancer, but is being increasingly used and studied. The idea is that we inject a special dye by the tumor. We use special scans to figure out which nodes are draining from that tumor. And then instead of removing all the lymph nodes in the neck or a bunch of lymph nodes in the neck, we're able to go just to that 1 or 2 lymph nodes, make a small incision. You can see a small incision, and we use that Geiger counter, a Geiger counter, which picks up the dye to remove just the 1 or 2 lymph nodes so that they can be tested. And in the majority of patients, we know that the cancer hasn't spread, and so that's all that's needed. In those rare cases, those about 20% where it has spread, then that allows further treatment. But we know then that the treatment is really needed because the cancer has spread in those patients. So regarding sentinel lymph node mapping for oral cancer, most patients with oral cancer have early stage disease, and there's no radiographic evidence of it having to spread. Oftentimes those patients are appropriately recommended to undergo an elective or preventative, essentially neck dissection, and sentinel lymph node biopsy represents a possibly a less invasive approach for these patients. So I guess that, the theme overall here is that there are, with the surgical techniques, is that there is a push to have less invasive surgical techniques. And again, the most critical thing is knowing when surgery is needed and when it's not, and how to combine it with the other treatments that we use to treat head and neck cancers. So that's the end of my section. I'm happy to look forward to questions later. So thank you.
Excellent. Thank you, Dr. Judson. Let's see if I can share my screen here. Okay. All right, there we go. Well, I would like to also welcome our patients who've come tonight. Really appreciate the support and interest. Give you a little bit more background about myself. I'm originally from California, went to college, I should say, at UC Berkeley, and then went to UCLA for residency, and then came out to start working for Yale about 12 years ago, originally in the Trumbull Bridgeport site, and then was fortunate to move down to this Greenwich site almost 2 years ago, and I've been thrilled with the team down in Greenwich, and it's been just wonderful to extend the Yale approach and the Yale quality down this far south into Fairfield County, and try to extend into Westchester County as well. I'm going to touch on some advances in radiation therapy tonight, and I'll start just by showing a little bit of the equipment. So you see in the top left here is a linear accelerator. It's one of the top of the line machines. This is the machine we have at Greenwich Hospital. It's called a TrueBeam. And this is called the treatment head. This is where it actually has come out. And this we refer to as the couch, although it's really a hard table. And this is a picture of a patient of ours who's in the treatment position for most head and neck cancers, which is on your back, arms at your sides, some kind of blanket to keep you warm. And then there's a mask, and you see a little more detailed mask here on the right-hand side. This is a special type of plastic that starts as a very thin sheet that's flat, and you put it in hot water, it becomes floppy, and you mold it to the person, and those holes in it become bigger so you can see and breathe through it. You can see it really conforms, it conforms very nicely to the head, the neck and shoulders. And this is the way that once we've designed a treatment, typically people are coming back for multiple days, in fact, multiple weeks for most of our treatments. So we want to make sure you're in the same exact position each day so that the treatment is going to the right place and not spilling over to places that don't need it. Some of the masks these days can have little holes for the mouth and eyes to allow for a little bit of a less claustrophobic feeling, but sometimes that's not possible depending on where the tumor is and what we're trying to achieve. A lot of people wonder, how are they kept safe, or how's the beam shaped? And if you look up into that head of the machine, there's something called a Multi-Leaf Collimator, which is seen here on the right. And it's a set of leaves, really metal leaves that come from each side, and they can create whatever shape we want within what starts as a rectangle. And these leaves are very thin to look at, but they're very tall. They're about 3 inches tall. And so, when you go to the dentist's office and you get the protection by that thin lead blanket, a thin lead blanket will not protect you from radiation that's a therapeutic radiation for killing cancer. You need something much thicker. And so our quote unquote lead blanket is actually in the head of the machine, and is appropriately thick and can do all these fancy shapes that we want. Another thing that we've done over the years is we've moved from something called 3D conformal radiation, which is usually a limited number of beam angles or beam shapes. And we've moved to, again, for most cases, something which is more sophisticated. It comes from more angles, more shapes, and usually takes a little longer. And because it's gotten more sophisticated in the shape of the radiation that we're delivering, we're even more critically reliant on making sure someone is set up properly. And a lot of times with head and neck treatment, people will have the ability to shift their head or neck a little bit, or tip their chin up and down, or perhaps they've lost a little bit of weight or sometimes a lot of weight during the treatment. And we need to make sure before we turn that beam on every day that we feel absolutely confident that we're on target and doing what we need to. So if you look on the right, you have the head of the machine here, but then you have these arms that stick off on the sides. And those arms can do actual imaging instead of just treatment. And they create what's called a cone beam CT. So before you get a treatment, you actually spin the machine around the person and create an image that looks like a CAT scan. And if you look on the left here, I'll show you how similar it is. So the kind of top left and lower right hand corners are a regular CAT scan that's been taken of someone's head. This is in the kind of jaw area. Oops. And the top right and lower left are the cone beam CTs. You can see there's a little bit of a difference in terms of the brightness and things, but really you can see remarkable detail. And the same thing here, this picture here. This is a treatment we've done recently for someone who had a tumor that was extending from the tonsil into the soft palate. And here again, it's almost hard to see, which part of this image is the cone beam, which is the regular CT. So it's remarkably detailed. It's not detailed enough, and it's not given with any IV contrast. So you can't use this during the treatment necessary to monitor for response to the treatment, although sometimes we can see a difference, but it is great for the alignment. I'll go quickly through this slide because Dr. Burtness touched on it, but just to highlight, in the US, there are approximately 65,000 new cases of head and neck cancer per year. About 60% are more advanced stage, and 75% more or less are tobacco and or alcohol related, and about 25% of all the head and neck cancers are viral related, like that HPV or another virus called EBV, the Epstein-Barr virus. But something I'll focus on a little bit more in this talk is also about this oropharynx cancer area. And those have roughly doubled in the last 30 years due to HPV. In fact, about 3/4 of oropharynx cancers in particular are HPV, and many of those arise in the tonsil. And the oropharynx, move into this here, is actually, it's a zone. Really, Dr. Judson was pointing this out too. We have two pictures here. One is kind of a classic anatomy picture from this famous anatomist, Dr. Netter. On the right-hand side is an X-ray picture. This is as if you're looking at someone from the side. And so you have, just point out here, the nose, the nasal cavity, the lips here, the tongue, come down the airway, getting down to the throat here. And so it's in this zone that's outlined in blue, and it includes the tonsils, the soft palate, that uvula hanging down the back of your throat, the base of tongue, and then what's called the posterior pharyngeal wall, which is really when you look at someone, you say ah, and you stare straight back past the uvula, you're looking at that posterior pharyngeal wall. So it's any of the cancers that are in this site, or in this zone, I should say, make up the oropharynx. And what's really interesting and encouraging is that when you look at these HPV cancers, which are now becoming more common in the oropharynx, you can see that the survival rate seems to be better than the HPV negative. And so this one famous trial that was reanalyzed, they saw that at 3 years, the HPV positive, and this is particular to this trial, so this isn't for all patients, but just in this one, you could see the HPV positive was 82% versus HPV negative was 57%. So a pretty big difference there. If you go down to the bottom, the local regional relapse, so you've given the treatment, but it comes back, was 13.6% if it was HPV positive and 35.1% if it was HPV negative. So we have the sense that definitely these HPV positive cancers are doing better. We're still curing a lot of people with HPV negative, and we're trying to do better with both of them. So the question is, how can we move ahead? So one idea that Dr. Burtness had touched on, I'll just say a little bit more here, is if we're doing really much better with these HPV cancers, in particular ones that people have a very limited or no smoking history, it's in this favorable risk HPV, can we actually de-escalate or de-intensify the treatment and still have the same results? So just briefly talk about 3 trials. There's this Ecog 1308, where the question is asked, what if we give some chemo first and see if that shrinks or actually makes the tumor seem to disappear? Then when we move on to chemo and radiation together, can we reduce the radiation dose? Now the trial is one that Dr. Judson mentioned, the Ecog 3311, where you get that special TOR surgery, and then the question is, could we reduce the radiation dose? And a third one is called NRG HN002, and they were comparing whether you could use chemo plus a lower dose of radiation, and how did that stack up against a traditional higher dose of radiation. And for that first study, they showed that the 2-year results for what's called progression-free survival, meaning the person is alive and the cancer has not progressed, were excellent. 2-year survival rates were also excellent, even in this lower radiation group, lower dose radiation group. The people who were able to use a lower dose after that chemo response, I should say. The second trial Dr. Judson mentioned, 2-year results looking really very encouraging with using lower dose after that TOR surgery. And on the last one, they showed that actually if you use the lower dose of radiation plus some chemo, actually looked a little better potentially than the high dose radiation group. So I'd say that more studies are needed to confirm some of these findings and to go on further and test more options, but for this to change everything, but it's really opened the discussion for when is it appropriate to de-escalate treatment, when should someone be enrolled in a trial, and like Dr. Judson and Dr. Burtness were mentioning, this multidisciplinary approach where people will talk about this kind of question and see who's appropriate and who gets these resources, who gets a different set of resources, it's just absolutely critical. So we're very lucky at Yale to have such a team. Now, on the other hand, once we move into a little bit of an intermediate risk or a higher risk population, maybe we should be doing something to actually increase or somehow augment the treatment. Maybe we can do even better. And there's one trial I'll just point out that actually Yale's involved in, EA 3161, where folks are getting standard dose radiation and chemo, but then we're experimenting whether it's kind of a plus minus use some immune therapy afterwards, and might that help? So we're excited to be part of that. And I believe that's in the New Haven site, Trumbull. We're looking to open that at Greenwich as well sometime soon. Now, on the radiation side, there's no doubt that radiation therapy for head and neck cancer is fairly toxic. I'd say of all the treatments that I do throughout the body, head and neck is one of the most toxic. I think it's absolutely necessary in some cases and can be life-saving, but it is tough. And I'm going to point out some things that we're doing to make ours better, but we are so appreciative of the supportive therapies like occupational therapy and nutrition, speech therapy. These things are absolutely critical for people to do well long-term. And we'll hear more from them in a little bit. But in terms of what we're doing radiation, I'll point out a few things. One thing is we're trying to minimize the risk of stroke later by limiting dose to the carotid arteries. We're trying to minimize difficulty with swallowing, especially even during treatment and long term. And we're trying to minimize dry mouth. And this is kind of an interesting and detailed slide, but in essence, what this is that, you know, treating head and neck cancer for radiation is extremely complicated. It's also, I'd say, one of the most complicated treatments we do. So you really just can't go to any radiation center and have the level of sophistication that's necessary. You need the top of line machinery. You need this kind of expertise where people really do this as one of their passions, and they're involved in a big team. And one of the reasons for this is that there's so many critical tissues that are in the area that we're trying to avoid at the same time. So if you picture, again, all the way to the right, that oropharynx zone, and then you move over to these pictures here, you can see all these things that are in color are all normal tissues that we would love to spare. So we have, like number 6, we have the tongue, we have the spinal cord back here, number 4, whoops. We have this structure, this kind of smiley face structure, number 2, which is called the pharyngeal constrictor. It's a muscle that helps with swallowing. All these things are critical, and yet these cancers are embedded in or near these structures. I'm going to point out also number 3, which is the carotid artery, because I'll come up in the next slide here. So one thing that we are starting to do, or have started to do, is doing for an early stage glottic cancer. Early stage glottic cancer is basically a voice box tumor, which is only on the vocal cord, hasn't spread anywhere else. And the traditional way to treat this is one beam from the right and one beam from the left, which results in the treatment that you see here on the left side of the screen. And if you look, this kind of circular or ovoid area that's in red is the area that we're really trying to treat in this case. And the green little kind of diagonal area is the part on the vocal cord that was seen by the otolaryngologist and physician team. And so this is great. This works very well. But if you look at these lines that surround, these are called isotopes lines, and these really relate to the strength of the radiation being delivered. And you can see that the lines go out more like a triangle, even though the cancer area that we care about is more like a circle. And so this includes this green circle and blue circle. Those are the carotid arteries. So this classic radiation that works very well delivers incidentally a bunch of doses of the carotid arteries. So a newer technique, IMRT, which is intensely modulated radiation therapy, where you spin the machine around, it enables you to have, as you can see these lines here, more of that circular look, so you can markedly reduce the dose of the carotid arteries. This has been tested. We know we can do it. Not all insurance companies will cover it. And the reason is, to be fair to them in this case, that the follow-up about whether we can see on the screen this makes a difference, but does this make a difference for patients long-term? We're really reducing strokes by quite a bit. And at this point, this has been out for about 4 or 5 years. And it's not clear whether we're having a huge difference later or not. But you can see that because of the difference to the normal tissues, we're always fighting for less dose of normal tissues. So we're seeing more and more of these treatments being done like the one on the right, as opposed to the one on the left, although both work quite well. And one question that was asked a while back, we keep refining, so this is a paper from 2010, was this, okay, listen, we want to treat these oropharynx cancers. We know we have all these critical structures nearby. We can ask our planning team to create a treatment that will start to minimize dose of these normal tissues. But if we do that, are we going to mess things up? Are we going to reduce our cure rates because now we've accidentally reduced the dose of the tonsil because the carotid gland was right next to it, or the carotid artery was next to it? And so this is one of the earlier groups to more formally ask this question. And they were specifically interested in that pharyngeal constrictor muscle, that one I was pointing out in the back that had that smiley face look, the esophagus, the larynx, the voice box, the saliva glands. And they ran this study, and the answer was yes, you could spare these things, at least to some extent, and still have excellent cure rates, local control. When we look at saliva and dry mouth, we know that well, we've known for years that the major contributors to that are things like the quote-unquote major saliva glands, like the parotid glands. And if we look at this picture here on the top left, the parotid glands are here and here, these bigger ones to the side, and we have these a little lower down, these submandibular, just in from the jaw. And we've known about these, and we've been trying to spare them, at least as best we can, for years. And then something interesting, we almost never find a new anatomy structure, a new functional structure, because this has been studied for so long. But there was a test called the PSMA, which is actually a special imaging test that was designed to help look for prostate cancer spreading around the body. When they started doing this test, which is now being used more in Europe, and it's just starting to be used in the US a little bit, what they noticed completely incidentally is that for some odd reason, this lighted up not only in prostate cancer areas, but also the saliva glands would light up. And that was fine, except when they did that, they found a saliva gland area that no one knew about. And it exists, if you look from the side, I guess I'm going to relate again to this image on the right. So you have the oropharynx area. So if you go just up, and I'm going to point down to this lit up picture here, this is more like the nasopharynx. It's if you go on the back of the throat and you go up a little bit, or if you go through your nose and go all the way back, you arrive at the nasopharynx. And there's an area called the torus tuberi that's there. And they found these glands, they're basically saliva glands that are embedded within that nasopharynx. And so they called them tuberial salivary glands. And this was literally discovered and then published in 2020. So we've now just started to try to design radiation where we can stay off those, where we're now trying, because what happens in radiation is if you don't attempt to spare something, of course you never will. If you know about it and have a smart design and work with a team, you can at least attempt to drive the dose down. A lot of times you can drive the dose down. So we're always excited to learn about new things like this, and always fighting for how we can reduce the side effects as much as we can. So that's it for me. Let me stop sharing here. And stop sharing, sorry. There we go. Okay, we're going to open up to the question and answer period. I want to start, and so at this point, if anyone, I see might be one question in the chat, if anyone wants to type in questions, so I see one page question here, or a participant question, I should say. So we'll circle back to that one, but I want to start if I can with our support team here. I'm going to start with one question for Lori Walsh, occupational therapy. What are some of the common reasons someone treated for head and neck cancer would be referred to rehab, PT, or OT? Oh, I think you're muted still.
Sorry about that. Primarily what we see with head and neck cancer patients are a number of problems, one of them being lymphedema, which would be swelling of the face, neck, tongue, or other, oral structures, secondary to, either the radiation or the lymph node dissection that might have been done to remove the cancer. And then the other areas that we see typically are things like myofascial pain. Frequently people will have neck and shoulder tightness. Sometimes they do a lot of protective guarding because of discomfort in the surgical site, and may have trigger points in the neck and shoulder range area. With that, we also see decreased range of motion of the neck, the shoulders, the face. In general, facial expression, muscles of facial expression can be impacted as well. The tongue can become very, very fibrotic, and some of that tongue motility is decreased, as well as the jaw mobility. So all of those areas can be affected. We see a lot of postural changes as well, especially when someone has had, significant neck dissection. They tend to become very kyphotic with a forward head position, and so they end up having secondary postural problems. And sometimes that also results then in limited shoulder range of motion. And basically we try to work a lot on improving their posture and alignment so that we can maximize their shoulder range of motion and prevent frozen shoulder and other restrictions. Basically the big thing is trying to also help improve their quality of life by maintaining as much function as possible, and teaching them some of the skills that they might need to be able to decrease some of the residuals that they get from the treatment. Teaching them how to do self-management so that they can basically have some control over the situation, because I think a lot of times that that they feel that that's been taken away, and teaching them how to do some things that can help improve their physical appearance, because also there's with some people, particularly those patients who have a lot of swelling, it's not something that you can hide. When we see patients who have arm or leg or other types of lymphedema, they can wear clothing that covers it up, but your face is out there, and when they have a lot of swelling, it can be very impactful in terms of being self-conscious. So if they can control that to some degree, it helps them to feel a little bit more themselves. So those are the primary reasons we see them.
Excellent, thank you so much. Next one for Susan Pritchard Downey in nutrition. What kind of, for patients undergoing chemo and radiation, what kinds of foods do you suggest during treatment? And does that include protein calorie drinks or protein powders?
Hi. A dietitian can help to identify foods that are appropriate right through the course of treatment. We always want to prioritize getting adequate calorie and protein intake. When you have side effects like sore mouth, sore throat, then it would be more appropriate to have softer foods, things that aren't scratchy, things that are not acidic or too spicy. So I have lists of foods like this that I give to our patients when they start treatment, talking about how meatloaf might be better than steak, that meatballs in a white sauce would be better than a spicy tomatoey sauce, for example. And if chewing is difficult, then I can provide suggestions for softer foods, cooked cereal, mashed potato, eggs, yogurt, pudding, things like that. Drinks like Ensure, Boost, and Orgain, for example, can be a useful way to add calories and nutrition. Here at Greenwich, we have samples of a variety of products, some clear products, some milky looking ones, milkshake type ones that patients can sample. They can be useful if you're not able to eat the full range of foods that you usually do, or your meals are getting a bit smaller than they used to be. They can be a useful way to add nutrition. We have products that cover a wide range of options. So for example, for people who are diabetic, we have less sugary drinks. For people who are vegans, we have non-milk based drinks. For people who prefer organic products or lower carbohydrate products, we have options that cover quite a wide range of needs.
Excellent, thank you. And Ellen Potter from Speech Therapy. Should I see a speech pathologist before my head and neck surgery or radiation treatment? And what is the role of speech therapy after surgery or radiation? I think you're muted still, Ellen.
Okay, there we go. So all things being equal, it's better for us to meet with the patient ahead of time before they start their treatment. That way we get a sense of their baseline. We can make some recordings. We get a sense of what their concerns are. A lot of what we do is education and counseling. So it gives us a good head start on that. Afterwards, particularly if a patient's getting radiation, as you know, we've mentioned fibrosis as a significant concern. So we like to get in there and start the range of motion strengthening exercises, particularly to avoid trismus, the tightening in the jaw. It's so important that we get those exercises started right away, and those exercises are likely to be lifelong. So I think the main concerns are swallowing, getting nutrition. We do different types of testing to see if a patient's, when they're able to eat by mouth, how to help them supplement, what techniques or strategies they can use. In terms of, I've had some patients who don't care that they're not eating because they don't have an appetite. They're more concerned with people understanding them. And there is a lot of overlap on that, but we do a lot of work on just general communication, functional strategies, and how to give them the best quality of life as they recover.
Excellent, thank you. Let me just highlight a little bit of the conversation that's in the chat for people who can't see the chat or phoning in. One person asked, are there any new techniques or new treatments for nasopharynx cancer? And Dr. Burtness was highlighting that there are some immunotherapies that are proving to help with disease control, especially when the cancer has recurred. And there are some radiation techniques like image guidance, as pointed earlier, or proton therapy and other style of radiation that can have some advantages. Another question came in saying, how many years does it take to introduce a new idea into trials, determine its effectiveness, and integrate into practice? And Dr. Burtness had used as an example that E3311 trial that we mentioned before with the transoral surgery and then the lower dose radiation. That was designed in 2011 and final results were in 2020. And then someone asked about post-treatment, some exercises or diet regimens that can lessen the chance of recurrence. Let's see, I would say, I mean, Dr. Burns or Dr. Judson can speak to this. I would say the exercise and dietary factors to me are less about reducing the chance of recurrence and more about improving quality of life and functioning. I think the main things we look at are some of those risk features, like Dr. Burtness was pointing out. You know, someone who's been smoking, can stop that, or drinking, can stop that. There are a few other things, but Dr. Judson and Dr. Burtness, any other comments about other ways of reducing chances of recurrence?
So there is some evidence that patients who have extraordinary degrees of weight loss during chemoradiation are at higher risk for recurrence. And I think this is not maybe where your question went about a fit person who's got no evidence of cancer and how can they live the healthiest lifestyle. But one of the reasons that we sometimes get kind of worked up about a patient who's lost more than 10% of their body weight, and one of the reasons that we think about feeding tubes in some patients who can't stay on top of their caloric intake, is that radical weight loss has been shown to be associated with a worse outcome. And we don't know if that's because of its effects on the immune system, although that could be part of the story. And that kind of radical weight loss can also have some effects on cardiovascular fitness that can increase your risk of not living as long from a non-cancer point of view. So just for those of you at whom I have ranted and raved about caloric intake in the past, I'm sorry, but that's why.
And I would say, just to add to that, just as a comment, during treatment, you know, we always tell people that, you know, your body's fighting so hard to repair the damage that we're doing, and we need to give it the fuel and the building blocks to do that work. If you're just losing, it gets into a vicious cycle where it becomes harder to do that, even that initial repair. That's why we certainly push people and value the input from nutritionists and everyone on the nursing team. Let me circle back to some of the questions here. One more for Lori Wallace. How do you treat swelling in the face or neck after treatment? And why is the treatment regimen for head and neck lymphedema commonly focused on self-NLV with less intensive outpatient treatment?
Okay. Well, normally I would start with evaluation, but we'll jump straight into treatment. Basically, there's so many different facets of this. One is, you know, in terms of drainage with head and neck cancer, positioning is really important, and that is part of lymphatic drainage. Usually because the lymphatics are in the supraclavicular area for the most part, during the day, people actually do pretty well. It's mostly when they lay down at night that they seem to get more of an accumulation. So when they wake up in the morning, they have, a more significant visible swelling. One of the absolutely most important things that we teach people during the course of treatment is manual lymphatic drainage to help stimulate the healthy, lymphatic vessels. And basically what you want to do is you want to open up the channels and go around the scar tissue to help redirect the lymphatic fluid that's collected in the face, tongue, lips, wherever you have, the accumulation, and try to redirect it towards the areas that are still healthy and still functioning, so that you can help reduce some of the firmness and the, visible swelling. We also typically do a lot of range of motion exercises. As I mentioned briefly before, you would look at their facial muscles and facial expression. You would look at their cervical range of motion, because frequently if they have very limited neck motion, that also impacts their lymphatic drainage. So the more they can move and mobilize their neck, the better results they have in terms of just keeping those areas open and allowing things to flow and drain better. We also go over oral exercises that crosses over sometimes into, speech. Typically we would involve other services if we felt that the patient needed multiple, disciplines. But if we're the only ones involved in the case, we would go over, oral exercises. As Ellen mentioned, the trimmus is a big issue. So there are some devices that you start something really low tech, like using stacked tongue depressors to there's devices on the market by Dynasplint, and I think there's another company that has a device that you put into the mouth and it gradually, slowly opens up the mouth, and you just try to build on that. Compression garments are also really critical. So usually I typically try to even do a homemade chip bag that's full of foam that people will wear, let's say, under a cervical collar or with a chin strap, to try to soften up some of the fibrosis. But there's a ton of different kinds of compression garments on the market that people generally wear at night to help soften the fibrotic tissue and reduce the swelling, because it provides compression that helps to allow for the drainage. So those are, some of the areas we work on. We also work on scar management. Sometimes people have a lot of hypersensitivity, scar adhesions, and just, general discomfort, and sometimes manipulating that very gently, because of the irradiated tissue is usually, really sensitive, but that can sometimes help. And again, I mentioned earlier, we also work on, myofascial pain and trigger points. A lot of times people are very, they're very forward and elevated, and it reduces their shoulder range of motion, as I mentioned previously. So all those things are areas that we would want to address. The reason that head and neck is, maybe not treated with the same degree of frequency that we see with arm or leg or other types of lymphedema is because it's such a focused area. And usually when we try to set up the home program where we're getting people to do their self-massage, we try to teach them that right away so that they can do that on their own. If they're doing it on a daily basis, they don't need to see us as frequently. Whereas with other body parts, some areas are harder to reach. And it also increases their sense of control, and they end up getting a better outcome if they're not relying on a caregiver, but if they're able to do it for themselves. So that's sort of a synopsis, I guess, of some of the things we do in treatment.
Perfect, thank you. And back to Susan, are there any foods or supplements that people should avoid before or during treatment?
We know that excessive doses, especially of antioxidant vitamins, can actually affect the outcomes of some treatments. So we ask that people avoid excessive doses of antioxidants. We actually don't really need people to take high doses of any vitamins during treatment. There are supplements that interact with chemotherapy treatments, and certainly by declaring all the supplements that you're taking to the intake team, we'll be able to advise you specifically if a supplement or other product that you're taking or herb that you're taking would make the treatment less effective.
Okay, thank you. And for Ellen, could you talk to us a little more? How would you help someone who has a problem swallowing through the drink after treatment? Some detail there. You're muted again, Ellen.
Sorry, not used to these Zooms. Okay, I should be. So typically we would just start doing what's called a clinical evaluation, just kind of getting a sense of roughly where they are, what they can tolerate, if there's any strategies we can use to help them tolerate, get food down. We have 2 different types of instrumental exams that we do to be sure that things are going where we think they're going. If one is a modified barium swallow, which is an X-ray study, just getting an image of the food and liquid going down into the stomach. The other is fiber optic endoscopic evaluation of swallow, which is endoscopy. Both of them will detect aspiration, food or liquid getting into the lungs or heading towards the lungs. But in many cases with oral cancer, your concern is more, can they get the food back to initiate it? So you might not need to start with that. You have to start with some assessment of, can you position them a certain way so that gravity works with you? Or can you try a strategy to help get the food or liquid down? There are exercises we can do to help with that. And as Susan mentioned, there are different modified diets that also would help with that.
Excellent, thank you. Let's see, a few other questions that have come in. One is, can you give us an update on plans for proton radiation therapy in Connecticut? So proton radiation is a little different than photon or X-ray therapy, which is much more widely available. It has a different way of depositing the dose, and it's known in certain, at least unique cases, that it's better than X-rays in terms of the normal tissue dose. This is true, let's say, for treating a spine and for certain pediatric tumor cases. But there are other scenarios where it looks like X-rays are probably better, and there are many scenarios where they are different, but probably very much the same. And so we really need more comparative data to really figure out when is one better than the other and how should we leverage the resources, especially since proton centers are much more expensive to open and maintain and are therefore much less available at this point. Now we are, there's something called a certificate of need that states have to issue to allow centers to move forward. So right now, I believe that Yale is still in the process of working with the state as to whether there's going to be approval. It looks like there probably will be, but I think that's being finalized, and then we can hopefully begin with the actual building of the center, which will be up, I believe, north of New Haven, I think in Wallingford, but anyway, definitely in the state, be the first one there, and we're excited about that. Another question, interesting, maybe Dr. Judson, Dr. Burtness is speaking to this. It says, I have an HPV positive cancer. Should I still get the HPV vaccine since I'm only 42?
That's a great question. I'm not sure that we know the answer to this. I don't know if you have thoughts, Barbara. I think it seems like it's safe to get the vaccine, but I'm not sure that we know for sure that there's a benefit. Do you have any other thoughts, Dr. Burtness?
I agree with that completely. We have not been advising it. There is evidence to say that you may be infected with one HPV type and the vaccine could protect you from another. But almost all the tonsil cancers that we see in the United States are caused by a single type, which is HPV-16. So once you've had it, not clear evidence that the vaccine would help. I think the one case where we might, if a person had recurrent precancerous changes that were always due to the same vaccine, we might think about doing it. There are therapeutic vaccines that are coming along that are designed to stimulate the immune response to the type of HPV that we know that you have. For people who have recurrent disease, there's a trial open at Yale now with a vaccine called Q Biopharma, given together with immunotherapy, that seems promising to us. But still a lot to be learned about this area, I think.
And let's see, another tough one here. Are there any new techniques or treatments on the horizon to facilitate the recovery of taste, sense of taste, both initially and longer term once recovery has progressed? You know, this is a big difficulty, both with radiation and certain chemotherapies, and it's definitely something people struggle with. You know, at this point, I'm not aware of anything that's has been able to accelerate that. I think we have a better sense of what the timeline is, if it's been radiation alone versus chemo alone versus the combination, and if it's radiation, then the main question is, you know, how much dose has gone to the tongue. If we're treating, for example, just in the voice box area, then there really isn't much dose to the tongue, and the patients do much better. But if we're up in that tonsil area, for example, then we're definitely giving a lot of dose. So we're frustrated along with our patients about you know, the relative lack of treatments for that. But I don't know, Dr. Judson, Dr. Burtness, have you heard about anything on the horizon that might be of help for them?
No, I think you got it. I mean, I think trying to minimize or reduce these side effects is probably the most important thing where we can. I don't think we have any treatments that are on the immediate horizon to help restore this once they're lost. Although there is some restoration just with time and recovery.
Just trying to look at the list of questions here again, but I think we've answered them all here. So I would like to thank everybody for participating tonight. You know, all the speakers, all the participants. We love the interest and you know, helping to share our knowledge and excitement about what's new and what we're trying to develop across the state with the Yale network and the very strong head and neck program that we have. Certainly, any of us would be willing to answer more questions, or if you're a new patient, want to, you know, schedule consultation or talk, the resources to do that. You can always call in to a center, so we'll get you hooked up. But hopefully you won't need us, of course, but just in case, we're happy to help out. So thanks again, everyone, for joining, and have a great rest.